Going to go live now. So I will introduce you, I will introduce the topic, and then we'll hand over the session to you, ma'am. A very good evening to one and all present here. I am Arpita from IGCP Group. I welcome you all to the webinar on the topic genital herpes in pregnancy. Now, genital herpes, a sexually transmitted infection caused by the herpes simplex virus, which is the HSV, poses significant risk during pregnancy. Pregnant women with active herpes lesions or a history of the infection require careful monitoring to prevent neonatal transmission. Antiviral therapy and strategic delivery planning are crucial in managing the condition to protect maternal and infant health. Proper prenatal care and timely interventions are essential to mitigate complications associated with genital herpes in pregnancy. To address this very crucial topic, we have with us none other than Dr. Sunita Chandra ma'am, and it's an honor for me to welcome ma'am and to introduce her to everyone. Ma'am has done MBBS, MD in obstetrics and gynecology, FICOG. She is a laparoscopic surgeon, obs and gynae, a reproductive endocrinologist, infertility specialist at Rajendra Nagar Hospital, and she's also the National Clinical Director for Morphus IVF. So with this very brief introduction, ma'am, I would like to hand over the session to you. Over to you, ma'am.
So very good evening to all of you. Thank you, Arpita, for introducing me. Thank you, IGCP, for giving me this opportunity to talk on a very, very important subject, which is very less talked about. Because actually, we do not think about these infections in pregnancy. We keep talking about diabetes, high blood pressure, thyroid, and so on. But we do not talk about these infections, which are very, very important to address. So you have actually chosen a very good subject. A very good evening to all my audience also. And at the end of the session, I would love to have questions from the audience. You're most welcome to ask your queries or even give your comments. And if you want to share something which I have not shared, maybe you can also share your experiences regarding herpes infection, genital and herpes infection. So, genital herpes in pregnancy. So, as the picture shows, you have multiple ulcers on the labial folds, on the anal area nearby, on the vulvar skin. I mean, the lesions are so typical that you cannot miss that it is herpes, genital herpes. So herpes simplex virus is a DNA virus. It has two subtypes, 1 and 2. One is mild, which causes lesions usually on the oral area, like around the lips. You must have seen sometimes rashes just on the corner of the lips, and that is HSV1. And HSV2 is the main culprit for genital herpes. The two types are differentiated by glycoproteins on the lipid bilayer envelope. Glycoprotein G1 is for HSV1 and G2 is for HSV2. Most individuals who are infected with HSV are unaware that they have contracted the virus because usually it is asymptomatic. Genital herpes is a common sexually transmitted infection, as Arpita said in the beginning only. And it has two types, 1 and 2, both of which can cause infection in the genital and anal area. As I was talking that HSV1 is usually responsible for the oral lesions and HSV2 is for genital, but now because of the more genito-oral contact, we have both the HSV1 and 2 causing this genital herpes. In women, genital herpes can occur on the skin in and around the vagina, the vulva, the urethra, and the anus. So typically we call it anogenital lesions. Individuals reporting recognition of their infection is only 10 to 15%. As I said, these usually the patient is asymptomatic, so they do not report about their infection. And the risk factors are females, duration of sexual activity, multiple partners, socioeconomic status, and previous genital infections. Other infections like HIV, they are more prone for herpes simplex infections. Younger generation, younger girls who are having sex at a very early age, 14 years, 15 years, they are at higher risk for having these kind of infections. HSV-1 infections were traditionally associated with oral area causing herpes labialis, gingivostomatitis, and keratoconjunctivitis, whereas HSV-2 infections occurred in genital region. However, because of increasing oral genital contact, either HSV type may be found in either location. Currently, approximately 15% of genital HSV infections are caused by HSV-1. However, HSV-1 is increasingly recognized as the etiologic agent for genital herpes infection, with a large proportion of new genital infections being caused by HSV-1 in young women. So, I mean, now there is no difference that whether it is HSV-1 or 2, HSV-1 has also been isolated in cases of genital herpes. So, this is again very, very important to know that HSV-1, which was previously thought that it causes only oral herpes labialis sort of things, now it is responsible for genital herpes also. HSV is transmitted from person to person through direct contact, and virus that contacts mucosa or disrupted skin initiates the infection. Incubation is usually 2 to 12 days, and during this period, HSV virus replicates, and this replication results in cellular destruction, inflammation, and virus then becomes latent in the sensory ganglia and reactivate periodically with either asymptomatic shedding or recurrent ulcerative lesions. All of us know that. ये virus कभी खत्म नहीं होता है, even if you have antibodies in your body, this can come at any time. Recurrences and subclinical sheddings are much more frequent for genital HSV-2 infection than for genital HSV-1 infection. And there are 4 types of HSV infections. One is primary, another is non-primary, first episode, recurrent asymptomatic viral shedding. Let's see what it is all about. Primary, where there is no IgG in the body, either HSV-1 or HSV-2, they exist at the time of outbreak, but there is no antibodies in the body of the patient. This indicates that the patient had no prior exposure to HSV. There is no antibodies in the body. In pregnancy, the incidence of new HSV-1 or HSV-2 infection is approximately 2%. And the rate of transmission is 50%, which is very high. So in primary, what happens? Lesion appears 2 to 12 days after exposure. Without antiviral therapy, the lesions usually last for 20 days. Viral shedding typically lasts for 12 days, and with the highest rate of shedding during the prodrome and the first half of the outbreak. तो कभी भी किसी को हम लोग हर्पीज डिटेक्ट करते हैं तो हमेशा बोलते हैं कि जब प्रोड्रोमल सिम्टम्स है तभी आप उससे अलग रहिए, एंड देन ओनली यू कैन एक्चुअली stop the transmission from one to other. Viral shedding usually ceases before complete resolution of the lesion. As in chickenpox, if you must have seen, the most important time for the persons to have infections from the person who is having chickenpox is when the lesions dry up. They have some escape, and when this escape dries up and shades off, then only viruses are there, and if you touch those skin lesions, you can contract that infection. But it is not like this in HSV, where the most important time is when the patient is having prodromal symptoms, that is the first half of the outbreak. Antibody response occurs 3 to 4 weeks after the infection and is lifelong. However, unlike protective antibodies to other viruses, antibodies to HSV do not prevent local recurrences. So this is the, bad part of HSV, that people do contract HSV infection, they do develop antibodies, but these antibodies are not completely protective antibodies. They do not prevent local recurrences. The symptoms associated with local recurrences tend to be milder than those occurring with primary disease. The lesions of a primary infection begin as tender vesicles bilaterally, which may rupture and become ulcers. All of us have seen that. Vaginal mucosa is commonly inflamed and edematous, and the cervix is involved in 70 to 90% of patients. Now let's see what is non-primary first episode infection. So here what happens? The systemic symptoms are fewer and shorter in duration. Duration is also shorter, that is 15 days, and shedding lasts for only for 7 days. In primary first episode infection, you have no HSV antibodies, while in non-primary first episode, there are heterologous HSV antibodies. That means इसको कभी infection हुआ था, पर कभी भी उसको symptoms नहीं आए. And this presented as non-primary first episode infection, although the body has some heterologous HSV antibodies. While in primary, there is no antibody. And what is recurrent? Recurrent infection is defined as genital HSV outbreak in a woman with homologous IgG antibodies to the HSV types. Recurrent infections occur most frequently during the first 3 months after a primary infection, especially HSV2. These lesions are classically unilateral on the labia. Approximately 14% of all pregnant women with a history of genital HSV infections experience recurrent lesions or prodromal symptoms at delivery. Among women with recurrent lesion at the time of delivery, only 3% of neonates will be infected. Recurrent HSV outbreaks may be symptomatic or asymptomatic. When present, most symptoms are localized like pain, itching, vaginal discharge. Lesions typically last only for 9 days and shedding lasts only for 4 days, not like 15 days or 7 days. Viral load tends to be lower in recurrent outbreaks than the primary lesions, and shedding tends to occur during the prodrome and early stage of clinical outbreak. Shedding is usually completed before the lesions resolve. So basically, if you see primary, non-primary or recurrent, it's almost the same. It's just that primary is the most virulent type. Non-primary asymptomatic is less and recurrent is even lesser. So primary is the worst. Asymptomatic viral shedding is episodic and brief, usually lasting only for 24 to 48 hours. And if a person is having asymptomatic viral shedding and you are in contact with that person, then you can contract that infection. He doesn't know or she doesn't know that she is having this kind of infection, but because the person is asymptomatic and they are just shedding the viruses. 1 to 2% of pregnant women with a history of recurrent HSV infection have asymptomatic shedding at the time of delivery. Co-infection with HIV may increase asymptomatic shedding of HSV in women. So HIV infection, if it is there, then they have more complications if these women contract HSV infections. So these are trust guidelines for the management of herpes simplex infection in pregnancy when the lady is HIV positive. So if it is primary, management is the same as recommended for all women with primary SSV infection. If it is recurrent, then you have to give acyclovir 400 milligram thrice a day for 32 weeks if a vaginal delivery is planned. Mode of delivery should be planned in accordance with the HIV guidance. We'll come to it later, how to deliver a patient who is HSV positive. This is just one slide to show when it is HIV positive, what to do for that. Perinatal transmission of HSV, which is very, very important, and that is why we are talking about it. So HSV can be vertically transmitted to the infant before delivery, during delivery, or after delivery. That means antenatal period, intrapartum period, or postpartum. Intrapartum transmission accounts for most of the cases. Maternal age of less than 20 years is a risk factor for vertical transmission. As I said, young patients have more severe infections, more chances of transmission to the babies. Antenatal, 5% of all cases of neonatal HSV infection results from in utero transmission. HSV has the potential for hematogenous spread to the placenta and to the fetus. And the spectrum of findings may be like other infections, cytomegalovirus, toxoplasma, rubella. Babies may have microcephaly, microophthalmia, intracranial calcification, chorioretinitis. Although these are very, very low, these are seen in very less number of babies who have contracted HSV infection in comparison to rubella, cytomegalo, or toxoplasma, which are very, very fatal. I mean, if the baby contracts those infections in comparison to herpes simplex, those babies are more prone to get these findings like microcephaly, microophthalmia, intracranial calcification, or chorioretinitis than herpes simplex virus. So intrapartum transmission accounts for most neonatal infections and occurs with the passage of infant through an infected birth canal. The use of a fetal scalp electrode increases the risk of intrapartum transmission. Likewise, instrumental deliveries. Likewise, if the patient is in labor and we are doing rupture of membranes. These fetal electrode sampling, all these things can increase the risk of neonatal transmission during the delivery process. From 75% to 9%, 90% of infants with neonatal HSB are born to infected asymptomatic mothers who have no known history of genital HSB. उनको पता ही नहीं होता है that they have herpes simplex virus. So usually the infection which goes to the baby is through the infected birth canal. And if we are doing some process, then the chances of transmission increases. Postnatal transmission of HSB can occur through contact with infected parents or healthcare workers or even family members. Perinatal transmission rate, intrapartum transmission rate depend on the type of clinical HSB infections. Lower rates are noted in presence of protective maternal antibodies that cross the placenta. Primary HSB infection transmission rate is 50%. Non-primary first episode, 33%, and recurrent infection or asymptomatic shedding is just 0 to 4%. So this is the mildest form of infection. The overall chance of neonatal infection from asymptomatic shedding in a woman with a history of genital HSV infection is estimated to be less than 4 in 10,000. That is 1% risk. To determine the frequency and sequelae of HSV shedding at the time of delivery, Brown et al. Obtained HSV cultures from 40,000 women and 202 women may HSV was isolated. Serology was available in 177 of the 202 cases. Based on the serology types, 177 women, 26 had first episode and 151 had recurrent infection. So you can see recurrent infection is very, very common. And then it was seen that first episode, the primary was in 9 only and 17 it had non-primary and recurrent was 151. The rates of perinatal transmission from women who had cultures positive for HSB at delivery were as follows. Primary, it was just 100%, that is 3 into 3. HSV2 is 17%, that is 1 in 6. And non-primary, it was 25%, recurrent 18%, and recurrent HSV2 is 0%. If the first episode is late in pregnancy, within 6 weeks of due date, the patient should be offered a planned cesarean section to reduce the chance of baby getting neonatal herpes. So, I mean, this is the guideline in every guidelines, whether it is RCOG, Green Top, or NICE guidelines, everywhere it is written that if the first episode is late, within 6 weeks of due date, the patient should be offered a planned cesarean section to reduce the chance of the baby getting neonatal herpes. And if the infection is before that, I mean, before 28 weeks, patient should be given a course of antiviral therapy, wait, and then again start antiviral therapy from 36 onwards till delivery. So this was trust guideline for the management of herpes simplex virus infection in pregnancy. If it is primary herpes, recommend CS to all women, as I said, at the time of delivery or within 6 weeks. If the woman declines CS, then offer intravenous acyclovir, avoid invasive procedures, fetal scalp electrodes, fetal blood sampling, artificial rupture of membrane, and or instrumental delivery. Consider neonatal antiviral treatment, intravenous acyclovir, 20 mg per kg every 8 hours. If it is recurrent herpes, offer vaginal delivery. CS can be considered on maternal request. Routine intrapartum care and invasive procedures can be offered if needed. If the patient is having premature rupture of membranes before 37 weeks, then as we have to manage for PROM, that is you have to give antibiotics, you have to give corticosteroids for lung maturity, that is all should be done. And management to be discussed with the patient, with the obstetrician, with the neonatologist and genitourinary medicine. And if the consider CS if the decision is made for immediate delivery or 6 weeks of the primary infection. If it is recurrent herpes, PPROM before 34 weeks, offer expectant management as in other patients, oral acyclovir. After 34 weeks, treat as any PPROM, including use of corticosteroids. Cesarean section is reserved for obstetric indications. There was one very important observational study that demonstrated neonatal transmission is highest in women who are seronegative, confirming the importance of maternal antibodies in preventing neonatal transmission. The presence of HSV2 antibodies appears to reduce not only neonatal HSV2 infections, but also maternal HSV-1 infections. Rates of neonatal HSV infections, both primary and recurrent, are greater with HSV-1 than HSV-2. Caesarean delivery is protective against neonatal infections. What is neonatal HSV infection? The significance of neonatal HSV infections varies and depends on the extent of the infection. Localized infections are most common and benign. However, serious infections can occur and can lead to death or long-term CNS morbidity. Neonatal HSV infections can be classified disseminated disease, central nervous system, and disease limited to skin, eyes, or mouth. Mortality has decreased to 30% for disseminated disease and 4% for central nervous system disease over the past 2 decades. Approximately 20% of affected neonates will have long-term neurological sequelae. A study by Kimberlin et al. Suggests that neonatal suppression therapy with acyclovir in infants with HSV may improve neurodevelopmental outcomes. So nowadays, actually, this should be offered to all the neonates where it is suspected that neonate has contracted HSV infection. So what are the symptoms of genital herpes? Usually local symptoms: intense pain, dysuria, itching, vaginal discharge, lymphadenopathy, and constitutional symptoms of viremia, fever, headache, nausea, malaise, and myalgia. Importantly, more than 75% of patients with primary genital HSV infections are asymptomatic, as I said in the beginning also. Asymptomatic primary HSV infections in pregnant patients at term are responsible for most neonatal HSV infections because they are asymptomatic. So that is why they have not received antiviral treatment. And that is why they give infection to the babies, because the babies then travel that infected birth canal and contract this herpes simplex infection. What are the detection methods? It is HSV culture, PCR, and zinc smear. There is actually no evidence for routine screening for antepartum genital HSV infections in our guidelines. As we are routinely doing screening for HIV, HBsAg, SCV, VDRL, we are not doing routine screening for genital HSV infection in antepartum period. Antiviral therapy mainly is acyclovir, which is approved for the treatment. It selectively inhibits viral DNA replication. So the important part which it does that it inhibits the virus replication. And that is the most important part. Any medicine which inhibits viral DNA replication works on these viral diseases. Another is valsiclovir and famiclovir, which is again is just a second generation antivirals, and valsiclovir is identical to acyclovir. Only thing is, once it is absorbed, it is converted to acyclovir in vivo. And that is why you have more serum levels with a less frequent dosing schedule. So what is the importance or what is the advantage of valsiclovir is that you need lesser number of doses. I mean, the frequency of doses is less in comparison to acyclovir, because you have to give it minimum thrice a day or 5 times a day according to the infection. In cases of acyclovir, while in valsiclovir, the doses are twice a day or maximum is thrice a day. Both are category B drugs. So recommended doses for antiviral agents for genital herpes infection: acyclovir first episode 400 mg TDS for 7 to 10 days, recurrent 400 mg TDS for 3 to 5 days. Valsiclovir, it is 1000 mg BD for 7 to 10 days, and for recurrent 500 mg BD. While famiclovir is 250 mg TID or 1000 mg BD. And if the genital herpes infection is in pregnant patient, then for primary or first episode, it is 400 mg TDS for 7 to 10 days. Symptomatic recurrent episodes, 400 mg TDS for 5 days or 800 mg orally BD for 5 days. Daily suppression, 400 mg TDS from 36 weeks estimated gestational age until delivery. Severe or disseminated, 5 to 10 mg per kg intravenously every 8 hours for 2 to 7 days, and then oral therapy for primary infection to complete 10 days. If we talk about valacyclovir, it is 1 gram orally BD for 7 to 10 days, 500 milligram for symptomatic recurrent episodes, and daily suppression 500 milligram orally BID from 36 weeks till delivery. And it is not available as IV preparation, so we are not talking about IV doses of valacyclovir. We talk about acyclovir. If we talk about safety profile of these antiviral drugs, 2010 Danish study assessed more than 800,000 pregnancies, suggests that exposure to acyclovir or valacyclovir in the first trimester is not associated with an increased risk of major birth defects. So these are very, very safe drugs and can be given even in first trimester. Antiviral suppressions for gravidas with first episode infections, recognizing that recurrent infections occur more frequently within the first year after a primary infection. Scott et al. Randomized 46 gravidas with first genital outbreak during pregnancy to either acyclovir or placebo beginning at 36 weeks gestation. Patients receiving acyclovir experience a significant reduction in the percentage of HSB recurrences and cesarean delivery. However, the reduction in the total number of cesarean deliveries in the enrolled women was not statistically significant. How to prevent vertical transmission with cesarean section? In women with HSB isolated from genital secretions at delivery, neonatal herpes occurred in 1.2% of infants delivered by cesarean birth, in comparison to 7.7% of infants delivered vaginally. So actually, we can prevent vertical HSB transmission if we are going for cesarean section. 1 to 2% only in cesarean birth, while 7.7% in vaginal births. Owing to the potential catastrophic nature of the disease, cesarean section is indicated in women with active genital lesions or prodromal symptoms. For women with primary or non-primary first episode genital HSB infection, during the third trimester of pregnancy, cesarean delivery may be offered owing to the possibility of prolonged viral shedding. In a non-genital lesion is present at the time of delivery, cesarean section is not indicated, as such lesions may be covered with an occlusive dressing. So it is only for genital lesions that we need cesarean delivery. Some special considerations like premature preterm rupture of membranes and HSB infections. An increased risk of transmission occurs with rupture of membranes. For pregnant patients with recurrent HSB infection and preterm premature rupture of membranes, the risk associated with prematurity must be balanced with the risk of in utero infection on a case-by-case basis. In women with preterm pre-labor rupture of membranes, there is no consensus on the gestational age at which the risk of prematurity outweigh the risk of HSB infection. If delay of delivery is appropriate, IV acyclovir is recommended to shorten the duration of active lesions. For pregnant patients with a primary or first episode of genital HSB infections and PPROM, no data are available for the risk of fetal infection for expectant management. Procedures like cervical placement should be avoided while an active lesion is present. Transabdominal procedures like amniocentesis, percutaneous umbilical cord sampling are not contraindicated in women with a history of recurrent infection, but not with active lesions. These abdominal procedures may even be performed in the presence of an active lesion if necessary. Invasive monitoring, as I said, fetal scalp electrodes is a risk factor for transmission. And however, if there are indications for the invasive monitoring, it is reasonable to use if no active lesion is present. Infection in the last trimester, women become infected with genital herpes in the last 3 months. The virus is passed on to their baby in about 30 to 50 out of 100 births. Because of the risk, women who get genital herpes in last trimester, cesarean section is preferred. In order to prevent infection in the last 3 months of the pregnancy, it is best to avoid sex with people who have genital herpes. This is also true when it comes to oral sex with people who have cold sores. Breastfeeding is not contraindicated if an active lesion is not present on the breast. Valacyclovir appears to be safe for breastfeeding women. Acyclovir was found in breast milk in concentrations that were higher than in maternal serum. The amount of acyclovir in the breast milk was only 2% of that used for therapeutic doses in neonates. To conclude, currently recurrent HSV infections account for only a small proportion of neonatal HSV infections. However, routine HSV separations with antiviral agents, especially in pregnant women, with a history of frequent recurrences may suppress clinical recurrences during labor and may reduce the need for cesarean deliveries in these women. In order to truly reduce the incidence of neonatal HSV infection, focus on the prevention and recognition of asymptomatic primary genital HSV infection should be there. In future, this might require a combination of PCR analysis for faster diagnosis as well as type-specific serology to identify pregnancies at risk for primary HSV infections. So thank you so much. Thank you for our patience listening. Thank you for your patience hearing. These are our New Year celebration with our staff. So every year it is customary to celebrate New Year with hospital staff. Thank you so much.
Thank you, ma'am. Thank you so much. It was a beautiful presentation.
No,
Uh,
stop sharing. No? Stop sharing. Yes.
ma'am,
Yes,
so
yes.
we shall start with the question answer round now.
Yes, sure, sure.
Yes, ma'am. So, first question is, and I think ma'am has already covered, still there's a question. How can pregnant women with genital herpes reduce the risk of transmission to their partners?
To their partners. So
Yes,
when
yes.
they have active lesions, they should not have sex. They should not even have oral sex. And second is, if at all they have, then partner should also be treated with acyclovir. So the most important is prevention. That means if whenever they have active lesions, they should not have sex, or they should not have even oral sex.
Right, ma'am. Right. Thank you so much, ma'am. Moving on to the next question. What counseling should be provided to pregnant women diagnosed with genital herpes regarding the risk of transmission to the baby?
Okay, so if a lady is HSV1 or HSV2 positive, I think it's fair enough to treat her with acyclovir. And if it is early in the pregnancy, there is hardly any risk of getting infection to the neonate. But if it is in the third trimester, then only it is very, very important. And then it has to be from 35, 36 weeks onwards, she has to take antiviral drugs till delivery. And the delivery should be cesarean, because you never know that the lesion is not appearing on the genital area. Lesion is not apparent on the genital area, but she may be shedding the virus asymptomatically. So if there is any chance of HSV1, HSV2 positive, and there may be some asymptomatic shedding of the viruses, then she should be counseled about cesarean section. And if there are lesions, then obviously you cannot go for vaginal delivery. She should go for cesarean to reduce chances of infection in the neonate.
Right, ma'am. What are the potential risks of neonatal herpes if a newborn is exposed to genital herpes during delivery?
So as I said, usually there are no symptoms. Usually neonates do not have, they have symptoms like neurodevelopmental delay may be there. They may have, if the infection is in the antenatal period, they may have microcephaly, microphthalmia. But usually it has been seen, if the infection was there in the pregnancy and it was treated well, they do not give any kind of problem to the neonate. Unless the infection was not treated, patient had acute infection and the infection went into neonate, then the neonate has to be kept in an ICU, the symptoms has to be watched, and the neonate has to be given IV acyclovir.
Right, ma'am. We have another question. What are the recommendations for the use of antiviral prophylaxis in the late stages of pregnancy?
So it is acyclovir 400 milligram TDS till delivery.
Right, ma'am. Let me check here if there are any other questions. No, ma'am, as there are no more questions for today. So with this note, we would like to conclude the session here. Ma'am, any take-home message you would like to say?
So I would just say, although in our guidelines, we don't have any guideline to test all the antenatal patients for HSV, but if there is any history of herpes, whether it was oral herpes or genital herpes or any kind of herpes infection, I think all the patients should be, we should take history from all the patients about herpes infection. And if it was there anytime, then antibodies HSV1 and HSV2 should be tested for that. And especially, I mean, we all take the history of multiple partners and any any kind of lesions to in her partner. If she doesn't have anything but क्या partner में कुछ इस तरीके के lesions है, तो basically if we take a proper history and we do the testing at least in those females where we are suspecting, we can actually reduce this chances of neonatal transmission.
Right, ma'am. Ma'am, thank you. Thank you so much for giving us your precious time. And of course, thanks to all the audiences for joining in and making the webinar a successful one. So with that note, ma'am, we are concluding the session here.
Thank you. Thank you. Have a nice evening. Thank you so
Thank you.
much.
Same to you, ma'am. Thank
Thank
you.
you. Thank you.